And since I'm not sharing my screen, I can, even though the screen's kind of far away, I have my laptop here and I have my other monitor there. I can get chat. So if you want to, if you have to question, but I think it's always best just to unmute your mic and have me go over something. Um, I have the two skeleton models. We're going to do the pelvis, the hip, and we might get into the knee depending upon our time. I have these pipe cleaners and I have some elastics that I'm going to use for muscle representation. I was hoping I was going to be able to move the camera, but I'm not. So hopefully, like from this view right now, are you guys able to kind of, if we were here, this is about the distance. Are you able to appreciate some of that? Are you able to see that? Is that close enough? Okay. All right. I got a thumbs up from Chris and a head nod from one other person. Okay. All right. Perfect. So, good. We'll be all right. So I wanted you guys to do the pre-lab for this, and I was looking through this book, and I probably should have looked through it in more detail for the assignments, but again, I do think the pre-lab and the post-lab of these are phenomenal. I think they're great study tools. Going through the landmarks and the muscle attachments, I can see how it can be a little overwhelming. And then particularly the labs. I think the labs are good labs, but I can see how there's just so much going on there. So for those that are watching this video as recorded and not live, just pay attention to the numbers that we go through. I'm going to whittle down some of the things. Some of the things like palpating superficially, we're just not going to get to it. There's no way that I can recreate that in a online situation. And I think really what that does is more for appreciating some of the muscle structure. But I think having the skeleton models to see like movement that's happening, that's going to be the priority. So as we go through, just keep track of, you don't have to do this one, don't have to do that one. So when you guys are following along today in the lab, what the intention is that you should be able to fill this out in its entirety during this time, scan it, submit it, and then your points are done. And then for those that are watching it as a recording, you can just kind of follow along, do the same thing, and get through that. But you could easily dog this and just finish this lab and not think about it, which to me it's fine. It's your grade, not mine. But just keep in mind the stuff that I'm focusing on is the stuff that we were limited in the last exam. And then definitely make sure you're doing the pre-lab and the post-lab. And what I will do is we'll go into the post-lab a little bit for each of these. So, all right. So if you guys go to the lab activities on page 185, so we're in chapter, I think it's chapter 17, whatever the pelvis is. And I think through our online session, we went through quite a bit of I'm sorry, this is respiratory system. I'm sorry. Chapter 17, page 193. All right, and so one of the things that I kept on talking about, but I don't know if we were able to really appreciate, was this concept of the crest of the ilium. So if this is your pelvis here, and if I'm standing right behind it, if you were to take your hands and you put them right on the front flat part of your pelvis, like you're gonna make a V right down to your crotch, right down to your pubic symphysis. If you put your hands flat there, you can feel some bony protrusion, and what you're feeling is this point right here, and this is the ASIS, so the anterior superior iliac spine, and what that is, it's the most anterior point of this crest of the ilium, and the crest of the ilium is on the top here, and this serves as the anchor point. Your abdominal muscles are coming down here. Everything on the inside of this fossa is the iliacus, and then on the outside you have all your glute medius, your TFL, and then your fibers of your glute max coming down through here. We're in class with someone. So this is a pretty regular. What you're really trying to do is when you're in clinic, you want to be able to get people to do this anterior posterior pelvic tilt, like this kind of pelvic rocking, where if you had a tail, you're sticking your butt back, or for an anterior pelvic tilt, or if you were tucking your tail between your legs, you'd be doing a posterior pelvic tilt. And in one of the lab things we're going to get to, notice that how as my pelvis rocks back and forth, my lumbar spine kind of follows. You can see that it flattens out here as I tuck my tail between my legs, and you can see that I get an arch as I come back. And if you stand up and play around with this, I mean, it's a really obvious connection between where the pelvis goes, the lumbar spine goes, and then up the chain. And what we're going to visualize today when we integrate the hip and the pelvis is that where the pelvis goes, the hip actually has to move too. And the pelvis really isn't moving. What's happening is that if this is my axis of rotation, and I have my axis right here through the femoral acetabular joint, the movement's actually happening there. So what you see is the pelvis moving, but the axis of rotation is actually here where the femur is coming into the acetabulum. So as I do an anterior pelvic tilt, I'm producing some level of hip flexion and getting away from extension, and vice versa, hip flexion, hip extension. So that's what we're gonna go through today. So anyways, when you palpate the pelvis, one of the things that you would do is, if you had the skeleton here, I had a bunch of stuff in my car yesterday, so when I was driving home, I had him in the front seat belted in, and I got a lot of looks when I was driving. So because I think maybe the red scarf that was there. But when you see these skeleton models, you're deceived by how much space exists between the rib cage and the pelvis. If you were in clinic, and I'm just doing this to get the arms out of the way. Yeah, that's fine. And you wanted to find the top of the pelvis. What I would have you do is you would come up from behind from someone and kind of push in a little bit. And if you pushed up too high, you'd be right on the rib cage, and you'd actually start to come down inferiorly. You'll find some soft tissue, and then you get to the point where you kind of push in, and you can actually, I'm pushing a downward force, you can actually push down, and you'd be right on the shelf, if you will, right on the iliac crest. People are always amazed by that, like especially for guys. It's about a finger width thick between where the rib cage starts and the pelvis. So if you just kind of palpate on yourself, you'll feel like you're at the bottom of your 10th rib, and then right there is right at the pelvis. Women might have a little bit more space, but when we look at the skeleton model, we said, oh, look, it's like a whole handful in between there. In reality, it's only like 1 or 2 finger widths that are there. So when you start palpating around, you might think, hey, you're on bone there. This is deceiving. Just realize that it's going to be pretty close, and you're going to be right there. And the main reason why you're looking for this for patient, or your first time with your patient, is that you're looking for any kind of pelvic obliquities. You're looking for distortions in the frontal plane. So you're looking for, in this case, let's use this model. You're looking for like one side of the hip hiked up higher than the other. So you'll see like, oh, that's a little level, and you'll back up, and you're just going to eyeball it. It's not that you're really going to measure this, but you just want to appreciate, especially if someone says they have a leg length discrepancy, or if there's like a limp or some kind of toe clearance, you want to start looking here to see, how's the pelvis? Is it shifted? It's one side up and one side down. One thing to keep in mind that is, if you have a pelvic obliquity where you have one side higher, you're going to automatically have the opposite side that's lower, right? Or if you have one side that's lower, the opposite side is going to be higher. You can't have the way the SI joint is, the sacroiliac joint, you can't have one side higher than the other unless there's some major structural, like there was a major trauma, surgery, a broken pelvis. And so unless you have some weird condition, you're not going to see that. Same thing is true too. If you palpate the front into the ASIS, what you're looking for to see if you have any distortion in the transverse plane. Is this side more forward than this side, right? Do I have some rotation that's happening? And if this side's forward, that automatically means this side's back. Or if the left side's forward, the right side's forward, that means the left side's going to be back. Okay. So that's the main thing you're looking for, is in the transverse plane and in the frontal plane, you're looking for some obvious distortions. And when it comes to sagittal plane motion, you're looking for what's called pelvic neutral. And we had said that if you were to look at a lateral view of the pelvis, here's your pubic symphysis right here, and there's your ASIS. And if I took a sheet of paper, in order to be pelvic neutral, I should be able to hit this, and it should touch in all aspects. Now, you would kind of do that here with a person, but if they have like decent amount of fat or belly hanging over or muffin, whatever might be in the way, you might not be able to really visually see that. So sometimes you might have to palpate and kind of see, okay, where's the pubic symphysis? And if as you build up your confidence and your professionalism and your deliberateness with your patients, palpating is not a big deal, as long as you do it in a really like deliberate and professional way. But if you're uncomfortable with that, you could easily just have your patient palpate, like just palpate the top of your pubic bone, right? You can show them and you have them do it. And hopefully you guys are learning some of these skills where the patient can put their hand on top, and then you can kind of palpate through their hand, so you're actually not making contact. And you can do the same thing for the ASIS. So, but what you're looking for is a relatively similar plane. So these 3 points, the pubic symphysis, the ASIS, and the other ASIS, should be relatively in the same plane. And if they're not, if the front's forward a little bit more, that means that if this was a bowl, water would be coming out of the front side here. That would be an anterior pelvic tilt. And if the pubic area is more forward, the SIS or back, that's going to be a posterior pelvic tilt, right? And then you start to, if you saw that and it was really something that got your attention, you'd be looking up the chain through the lumbar spine or down the chain into the hip and in the lower extremity. In the back here, you have the sacrum and you have the tailbone and you have these SI joints that we keep on talking about where we say that there's not a lot of movement there. And in the sagittal plane, there is a little bit of movement, but you're only talking about like 1 or 2 degrees. That's just enough to allow a little bit of separation of the pelvis during gait. When one leg's forward and the other leg's back, so like your right leg's in hip flexion, and your left leg's in hip extension, and it allows for that capturing of the potential and release of the kinetic energies. But this is stabilized. It's a mobile joint. It's not a bony fusion, and there's quite a bit of connective tissue that's there. And this is really filled in. Like you could see, if you look at a skeleton, you look down here, there's actually quite a bit of a gap. So if this is the ASIS in the front, this guy back here is the PSIS, the posterior superior iliac spine. And that's also a pretty easy landmark to find. If you see people that are relatively lean or fit, you would see like two indentations right behind the back there. And it's not so much an indentation as it is a protrusion of this. And in between there, right on the sacrum, there's a whole bunch of muscles that are there. You have the base layer, the multifidus, which is part of the trunk and spine, which we'll talk about in the previous unit, in the next unit. And then you have your glutes coming in and attaching here. Your glute max comes in and attaches all through the sacrum and comes on in. So really, it's just like that how much of the glute max is creating a shelf, and how much reduction in body fat do you have. But those are the two pretty palpable landmarks. The PSIS and the ASIS are pretty easy to find. And if you're doing a palpation in your musculoskeletal course, if you become really good at finding those 2 points, that's kind of you get your bearings pretty easy for that. Outside of that, there's really not much you're going to do. If you start to get into like soft tissue work or any type of things like that, you're really not going to be doing more belly work up here. You might get into some attachment points down here at the at the ischial tuberosity with the hamstrings. But most of the work you're going to be doing is in the belly of the muscle. And if you get into like women's health or anything like that, you would be doing more pelvic floor stuff. And what's interesting is women have accessibility, men don't. And to be able to get into the pelvic floor aspect, you can actually access the pelvic floor through the posterior component. The coccyx, the tailbone, is the anchor pointer, is the base of a lot of the pelvic floor musculature. And you can, if you get someone on their side and relax enough, you can actually palpate down and in, and you can almost hook in, and you could palpate the lateral side or the coccyx to get to those muscles without having to stick a finger in someone's butt or in their vagina, right? That's kind of the so there's no penetration with that. So people kind of forget that from the palpation component. They think they have to go internally, but you can actually access some of those musculature from the side laterally, and it's a better experience for you and the patient, right? So in terms of palpation, I think that's all we're really going to talk about. What I really want to focus on is the pelvic motion and the coupled spinal and hip movements. And again, the hip lecture is a little premature. We haven't talked about the spine, but we should, at least you should have some understanding that what spinal flexion looks like. So if this kind of curls into a ball like you're doing a sit-up, that's spinal flexion. And then standing up straight and sitting really tall, that's spinal extension. And we talked about what an anterior pelvic tilt is and what a posterior pelvic tilt is. And if you look at your page 195 and you look at number 4, what we're going to go through is look at the coupled motions that happen with sagittal plane, transverse plane, and frontal plane movement. Yeah, let's use this guy here. So if I have my legs stable, I'm standing on the ground, and I do an anterior pelvic tilt. So an anterior pelvic tilt is that I have if my pelvis is a bowl, water's coming out of the front. What's going to happen is it's going to be like you're arching your back. And as you do this, you are rotating the pelvis forward as you come forward. And if you kind of if you actually if you guys stand up right now and kind of do that, go ahead and stand up. Let's just do it together, just so you guys can experience this a little bit. First, start with a posterior pelvic tilt. So kind of tuck your tailbone under between your legs, and then notice what your back does. And then I want you to reverse that. Go through an anterior pelvic tilt. So you'll put one hand on your pelvis, one hand on your back, and just kind of go back and forth a little bit. Kind of rock the pelvis forward and rock the pelvis back. And what do you see happening in the lumbar spine? What's happening there? As you go into an anterior pelvic tilt, I can see everyone, especially Natalie and Chris, because they're lateral, but you're seeing an accentuation of the curve of the back. So you're getting lumbar extension. So as the pelvis goes forward, you're getting lumbar extension. And when I say forward, I'm an anterior pelvic tilt. And as the pelvis goes back, rocking under, you're flattening out your back, you're getting lumbar flexion. So with an anterior pelvic tilt, that is taking the sacrum from both sides here, and it's bringing the sacrum forward. And if I keep the spine stable and I go forward, you can see that it's jamming into lumbar extension. And as I take the pelvis and I tilt it back, you can see how the pelvis kind of relaxes, or the spine kind of relaxes a little bit and goes into lumbar flexion. So now that's above the pelvis. That was what's happening with anterior pelvic tilt. You're getting extension. You're getting the opposite motion in the sagittal plane at the hip. As the pelvis is going forward and the leg is staying firm on the ground, if you think of an anterior pelvic tilt, think of it as just going anteriorly. And if something above the femur was steady and you're going anterior, you're creating hip flexion. And if I go posterior, if I do a posterior pelvic tilt, that would be the same as me doing hip extension. So if you want a neat way of memorizing or just kind of a correction, whatever the spine's doing, the hip's doing the opposite. So if you're doing anterior pelvic tilt, you're getting lumbar extension, hip flexion. If you're doing a posterior pelvic tilt, you're getting lumbar extension and hip no, I'm sorry. You're getting lumbar flexion and hip extension. And again, if you don't have to do it now, but if you grab your femur and you go through an anterior posterior pelvic tilt, you'll feel the pressure as you go into here. Is a posterior pelvic tilt. You're going to feel the extension happening through the hip. You kind of feel pressure back. You'll actually feel the glutes kind of contract a little bit. And as you go forward into an anterior pelvic tilt, you do lumbar extension, you'll feel the hip flexors, which are producing hip flexion. Thought I had to sneeze for a second. Don't. Okay. So any questions on anterior posterior pelvic tilt? That's sagittal plane motion, and that's when you're doing bilateral movement, and that's when you're closed chain, when your feet are on the ground. Because if I'm in open chain, let's say I'm doing a hanging leg raise, I'm hanging from a bar, and I do an anterior posterior pelvic tilt, I'm going to get similar. I may get similar back motions, but since my feet aren't stable to the ground, they are free to do what they want. They may or may not be obligated to do that, right? But 9 times out of 10, your patients aren't going to be hanging from a bar, right? It's going to be where you're going to be doing a lot of this is with standing posture. And I didn't see anyone do it for people that are sharing their video when they're doing this anterior posterior pelvic tilt. But what you'll see clinically is you'll see people go through this anterior posterior pelvic tilt, and they can't move their shoulder girdle independently of their pelvic girdle. So what you'll see is more of this as they roll their pelvis back and forth. they don't have the motor control or coordination to separate this and keep this stable and go through these motions. And I think I've shared with you guys many times that people that are dealing with like disc issues or back issues, it's because all the sitting that we do and this lack of mobility through this to be able to control an anterior posterior pelvic tilt. Okay, so let's look at frontal plane, which is the next aspect. So terminology gets a little weird here. Your book uses a lateral pelvic tilt. I like to use the terminology like a hip hike because that's it's usually what you're seeing. So if I do a hip hike, I could be doing a lateral pelvic tilt, and if you do a pelvic tilt, if I do an anterior pelvic tilt, the front of the part is getting lower and the back is getting higher. If I do a posterior pelvic tilt, the back is getting lower, the front's getting higher. So if I do a right pelvic tilt, what that means is that the right side's getting lower, which a right pelvic tilt is the same as a left hip hike. A left pelvic tilt, because the left side's getting down, you're tilting that side to the side, the right side's getting higher. So a left pelvic tilt is the same as a right hip hike. I do think, I mean, most of the textbooks that I see use the vernacular, the pelvic tilting left and right. I think most people clinically, especially in a sports setting, will use the hip hike as a more of a normal vernacular. So just they mean the same thing, but they're looking at opposite sides of the spectrum. Remember, you can't do a right hip hike without getting a left hip drop. So a left pelvic tilt is the same as a left hip drop, but it's also causing a right hip hike. So it doesn't matter. Just make sure you're keeping track of that vernacular. Actually, hang this guy up on the again. Okay, so if I try to keep my torso as steady as possible, and I do a left hip hike or a right pelvic tilt, the sacrum tilted with the pelvis, right? Both sides of the innominate are coming together onto that sacrum, and it's like two hands on the steering wheel. If one side goes down, the other side's going up, and if the left side goes down, the other side's going up. So if I do if each of my hands are the pelvis here, and I do a right lateral pelvic tilt, you can see if it wasn't connected, that the whole thing would go like this, right? And so if I wanted to keep my eyes level to horizon, I would have to laterally flex my spine to stay that neutral. So a right pelvic tilt creates a opposite or contralateral lateral spinal flexion. So if I do a right pelvic tilt or left hip hike, if that's tilting to the right, my body, so if I do this, my body's going to bend now to the left to keep my body upright. Okay. And again, this is assuming both legs are on the ground. So a right pelvic tilt is going to create opposite or contralateral lumbar lateral flexion. And then a left pelvic tilt or a right hip hike, it's going to create right lateral pelvic flexion. I'm sorry, right lumbar flexion. Because where the sacrum's going, where the tailbone's going, or I'm sorry, where the pelvis is going, the sacrum's going, and it's creating that motion through the lumbar spine. So now we look at the hips, and if both legs are on the ground, let's say I stabilize here and I drop this hip down or lift that hip up, look at the space here between my hand here. This is the femur, and there's the ischial tuberosity. If I do a right pelvic tilt, lateral pelvic tilt, did that space get bigger or closer together? It got wider. So I was moving away from midline. That's creating hip abduction, abduction. On the same side, or on the opposite side, but same movement, look at the ischial tuberosity here, and look at the femur here. If I do a same thing, a right lateral pelvic tilt, you'll see that the opposite happened, that this space got closer. So that's hip adduction, adduction. So you're doing hip adduction, hip abduction when you're doing these pelvic tilts, okay? Now, I'll be honest with you, there's not a lot of situations where you are both legs on the ground and you're doing this motion. The way this would really look is if you're doing more of like instead of you doing a hip hike, it's more of a hip thrust to the side where you're kind of doing one of these joggers. So if you guys ever end up working in a clinic when there's a therapist there that does McKenzie type work and for lumbar aspects, some of these movements where you're moving the shoulder girdle laterally, trying to maintain frontal plane movement, or keeping your shoulder girdle stable and doing more of these hip thrusts to the side. I mean, even me doing this right now, I can feel how stiff I am. This is not a movement that we do a lot, right? We don't do a lot of this movement, and if I would encourage you guys to play around with it. But if you did this, if I did this, I did my left hip thrust. What this is creating is the same as me doing a right pelvic drop, left hip hike, and so you can kind of see that I had to, in order to counteract it, I had to laterally flex my lumbar spine to the left. My left hip is doing adduction, my right hip's doing abduction. If I go to the side this way, it's just the opposite, right? Left pelvic hip drop, right hip hike, and then the associated, back and forth. Where you understanding this coupling is usually when you're in single leg stance, and you can't see it because I'm behind the table. But if I'm standing here and I'm supporting through my left leg and I pick up my right leg, that's what wants to happen, right? What wants to happen is a right pelvic drop, but you don't. Your body stays in this position. So how you would be questioned like this on a licensing exam or on this test isn't, hey, are you able to identify that pelvic motion? But what would happen in terms of what muscles would be responsible to prevent a right hip pelvic, a right lateral pelvic tilt, right? So if I'm standing here, and it's good to appreciate that I would do a pelvic tilt, and this would be happening if I pick up my right leg, right? So if I pick up my right leg, gravity wants to do this, but it's not happening, right? But this is what wants to happen, and so the muscles that are preventing this from happening are the agonist or the concentric muscles in that phase, okay? So it's just like a heads up that's how this would be tested or questioned, is not, hey, do you understand the movement? But in single leg stance, a right lateral pelvic tilt or left hip hike wants to occur, that's going to be my left hip abductors that are going to be preventing that from happening. And when I pick up my left leg, this is what's happening. It's going to be my right hip abductors that are preventing that from happening. So does that make sense? Cool. Okay, for 5, we looked at the anterior posterior pelvic tilt. What plane of motion is that happening in? That's going to be forward and back, right? That's going to be your flexion and extension. It's always occurring from anatomical in the sagittal plane. Your lateral pelvic tilt is going to be your frontal plane motion. And then the thing that we didn't talk about in terms of musculature is the transverse plane motion, which is rotation. And actually, this one's the easiest to kind of keep track of. If I turn my torso, like if I turn my head this way, you would all say that, hey, he's looking to his right or he's looking to his left, right? Or I'm turning to my right or turning to my left. And so that's as easy as saying, hey, if you're turning to your right, that's right rotation of the cervical spine, or in this case, the pelvis, or left rotation of the pelvis. And that's going to be your transverse plane motion. So 6, 7, and 6, 7, A, and B, these are all like clinical palpation things, and this is just more practical application for you to kind of see any kind of oddities or issues. Being able to do it is one thing, and I think you'll get your musculoskeletal, but being able to appreciate what's happening here. So we're not going to go through like say 7A, but I would like particularly number 2, 7A number 2. This is like when if someone lifts their left leg off the ground, being able to appreciate what's supposed to happen and what you see happening and what muscles will be responsible for doing that. So if I was studying for this exam, I would be setting up these scenarios and kind of drawing things out and saying, okay, if I'm standing here, the pelvis is dropping, that's creating hip adduction on the right side and left pelvic drop, which would be causing that's the eccentric phase. That's what gravity wants to do. So I'd be thinking of the concentric activity that would be preventing that. So hip abductors, and then what spinal muscles are associated with the left pelvic tilt? It's going to be the opposite side. So it's going to be the erectors that are going to help pull that out. Because if I'm doing this, which is left lumbar flexion, it's going to be the right erectors and the right like obliques and everything that's going to be pulling that together. So then what 8 gets into, and it gets in through 8 and 9, 8 looking at the agonist and 9 looking at the antagonist that would be tight, is now after you identified the joint actions, are you able to associate those with a particular musculature? This is where your studying is going to come in and knowing which muscles are your hip flexors, which muscles are your hip extensors, which ones are your abductors, and so forth. And what we haven't gone through yet are the muscles of both. So we haven't looked at like the erector spinae or the obliques or the abdominal musculature, but this is tied in with that. So when we look at the anterior pelvic tilt, what muscles create anterior pelvic tilt? In order to answer that, you have to go back and see that the anterior pelvic tilt is related to hip flexion. So then your hip flexors are iliopsoas, rectus femoris, right? Anterior fibers of glute medius, and TFL. So those would all be your hip flexors. Those would all be involved in your anterior pelvic tilt. Your posterior pelvic tilt then would be your hip extensors. So these would be your hamstring musculature, all of them except for your short head of your biceps, your adductor magnus vertical fibers, right? Because like a hamstring group, hip extensor, your glute max, your posterior fibers of glute medius, your glute minimus. Right, so that's where 8 comes into play. So when you're again, and it's just a practical application of the of those. But I would know not just the extensors, flexors, or ab and abductors. Make sure that if you're able to identify extensors or flexors, you're able to say, hey, it's these muscles here. So if you're doing an anterior pelvic tilt, you're creating hip flexion. That means you're creating hip or spinal extension. So it's going to be your extensors for that particular movement, right? And that's going to be erector spinae and latissimus dorsi and things that we haven't really got into so much. And then for B, which muscles would assist the trunk muscles to produce an anterior pelvic tilt? So the hip muscles would be the flexors, right? So any questions on that? Do you need me to go through those? Those are pretty straightforward. But like I said, those are the easy questions. I would definitely know the muscles that are involved in that. Number 9, we've talked about already, the anterior pelvic tilt. It's creating a, so again, terminology that we'll get into in the next unit. You have your kyphosis or lordosis. You have your accentuation of the curve or flattening of the curve for now. If I do an anterior pelvic tilt, it's creating a lordotic curve or lumbar extension. And if I do a posterior pelvic tilt, it's creating rounding of the back or a kyphotic or a lumbar flexion. So then number 10, what it gets into is it's looking at maybe helping you appreciate the necessity of pelvic mobility and how it's important. So when you think of like a deep squat, which most people can't do appropriately, when you look at from like a training perspective and you look at deep squats, these are normally what some of the things that you normally see. Some of the faults that you see is you see when you the deeper you go, you lose that stability and you start to do what's called a butt wink, right? You start to tuck your tailbone underneath. A little bit of butt wink is normal. I wish I didn't have all the stuff in the way that I would show you. But as you go down into a squat, you do round the back a little bit, and it's not a lot. It's just a little bit to put tension on the thoracolumbar fascia, on that connective tissue that's here that is the relay between the glutes, the lats, and everything there. And we'll talk more about that tissue when we talk about trunk and spine. But what you're really looking for is like the significant, like you'll see a little bit of flattening of the lumbar spine. You'll see a little bit of like lumbar extension. But what you see as a distortion is this really tucked under pelvis. And why that's happening, it's usually attributed to tight hamstrings, and it's actually not tight hamstrings. What it is, it's remember you're strongest in mid range, and what's happening when you are going down into a deep position to squat, you're really not changing hamstring length at all. You're shortening at the knee, but you're lengthening at the do is that your body's strongest in mid range. It's trying to maintain that mid range position at all times. And so as you go down and you're shortening at the hip or you're shortening at the knee, your body doesn't want to lengthen there. It wants to stay into that tight position. And it's because of muscle length, sarcomere position, but not because the muscle's too tight. It's because it's too weak in that position. And so, some of the strategies is to strengthen hamstrings and more importantly, to strengthen hip flexors. But that's what you're going to see sitting in a deep position. You're going to see a butt wink, which is a posterior pelvic tilt, which is the deep position of when you're going to need to use your hip extensors, and it is creating lumbar flexion in that bottom position. So be sitting high in a stool. Think about if you're sitting so high and you're kind of dangling, your feet can't touch the ground, you're going to kind of scoot your hips back a little bit or scoot your hips forward a little bit. And that's actually going to put you into a posterior pelvic tilt. I like. If you go down, if you're trying to scoot forward, yeah, what am I thinking? If you're trying to scoot forward, you're going to try to tuck your tailbone forward more. Oh, you're right. I was right. Let's see here. You're sitting on a high stool. Oh, okay. So your feet aren't dangling. I'm sorry, I'm reading it wrong. So your feet are on the ground, and you're trying to reach your butt up to get onto a high stool. Okay, so it's different. So you're trying to reach your butt up. Anytime you try to lift your butt up, that's actually a cue that you can give your clients or patients when you're working with them. Is if you're trying to lift your butt up to get onto something, you are doing an anterior pelvic tilt to lift your butt up. So I'm sorry, I was reading it that you're on a high stool and your feet were almost touching the floor, but it's just the opposite. Yeah, a lot of these are tied to the trunk and spine. So like what C and D are looking at is looking at your rotational ability, and your ability to twist and rotate through the torso is also predicated on your pelvis being able to twist and rotate. So if you're doing activities like throwing a ball where you're trying to throw and rotate, if you are standing and your feet are on the ground, your pelvis is able to move through a range of motion because the hips are stable, so the hips are the ones that are restricted because they're connected to the feet, and you're able to generate that force. And so when you throw a punch or kick or throw or even just walk, you're able to rotate. So the shoulder girdle and the pelvic girdle are able to counter rotate. Think of this as like a spring, and as one goes the other way, this is going the other way. It's storing up tension so it can release to the opposite direction. So the better mobility you have through the pelvis, the more force you're going to be able to generate. If you sit and you block now, instead of the feet being blocked on the ground, you're locked at the ischial tuberosity, you're losing some of that range of motion, and now you're not going to be able to throw as effectively. And this might impair performance, but let's say you're trying to maybe someone's compensating for the hips and you want to focus more on upper body type components, that you might want to put someone in a seated position and have them throw to kind of see if you can tease out any kind of things happening above the pelvis in the shoulder girdle. But you would expect a decrease in the ability to throw and perform if you don't have the appropriate mobility through the pelvis. It for the pelvis mobility, looking at how it moves, and I think the biggest takeaway is looking at those coupled movements, looking at how the pelvis is moving in the sagittal plane, how the pelvis is moving in the frontal plane, and the pelvis itself is just the thing that's moving. This is really coming from musculature that deals with lumbar flexion, extension, and lateral flexion, or hip flexion, extension, ab and abduction. So making sure that you know the musculature through that. Any questions or anything you want me to review?
Hey, Jonathan, can you hear me?
Yep.
On the subject of the butt wink, I'm just curious. Could it be problematic, let's say, if someone's doing a weighted, standard squat, and then they have that butt wink or their spine flexes? Would that be a problem for a disc?
It depends on the loading. So where you see, like you can see like a little herniated disc right here. A lot of this is coming from more like bending and twisting, but the it depends on the volume. So are you an athlete that's working out 3 or 4 times a week and you're regularly getting there? That might be problematic. Are you not? Are you deconditioned and you got there from one day of hard work? That could be problematic. Ideally, you want to minimize that butt wink. And unfortunately, when we look at like our traditional exercises like squat and hip hinge, which I think are some of the best exercises you can do, they've been infiltrated by the sport of powerlifting and the sport of bodybuilding. And so in our heads, like our old high school coach or the magazine we read, they're saying that you have to get really deep in your squat. And if you saw someone squatting like this, you're right, back in the day, you would criticize, oh, you're not getting deep enough, right? Because there's some magical threshold that they have to get down to. And that's part of the beauty about being in the therapeutic exercise field is that if someone's functional range is right there, that's fantastic. If you can be patient enough, it's the journey, not the destination. So I wouldn't force someone in that bottom position. I would progress them into that bottom position. And I would make damn sure that they're able to control that entire range of motion coming down there. A lot of times it's harder to work with, let's say let's say you get someone that works out regularly and they hurt their back. Sometimes you have to take like 3 steps back before you can start moving forward. And when I teach in the personal training program, and I get meatheads all the time through that program. And I remember one guy, he was a beast, right? He was a total beast, but he was squatting like 475, 500. He had, in order for him to have appropriate form, he had to drop his poundage down to like 375, 350, which is still a lot, but for him it was like but it only took him like 6 to 8 weeks to refine his technique, build up that hamstring flexibility, and he shot past like 5 1/4, almost 600, right? So to him, that was like fascinating that he was able, but he committed to the process. And that's what you're going to be dealing with is people that are so ingrained on that number and getting down in that bottom position and these arbitrary things without taking consideration the function of the skeleton, right?
So would that always want to be addressed if you see someone who's squatting and they have like a repetitive butt wink? You would want to address that.
Well, remember what I said. This a little bit of butt wink, this subtle butt wink is okay because what's happening is your body's transferring load from the musculature to the connective tissue, and you don't want to rob the body of the ability to do that. That's a normal functional process. It's the volume. So if you butt wink like once per workout towards your end of your sets, then it's probably okay. If every single rep is doing that, then I would change it. So if I saw it once in a while, I'd say, hey, and it's on a higher PR or like a big lift, that's just normal function. If it's like every rep, particularly starting with the warm up, no, that's a training fault that's eventually going to add to injury. And then let's bring performance into the therapeutic realm. Most of the people you're going to be dealing with, the closest thing to squatting is them getting on and off the toilet, right? So teaching them just how to be in that position where a lot of people, if you think about like if I was in the room with you guys right now, I would guarantee 99% of you, the way you're sitting, your pelvis is in a posterior pelvic tilt. Your ischial tuberosity is forward. And where you should be, everyone always tries to focus on fixing that through lumbar extension, but it's really about pelvis positioning. It's about getting that pelvis in an anterior tilt so you're not sitting on your tail, and then you're actually able to relax through the spine. And when we get into trunk and spine, I have a couple of videos, like a TED talk from Esther Gokal, and talks about this stacked sitting and stacked spine that shows that we've just been approaching this from the wrong aspect. It's your pelvis is your foundation of your back, and from sitting all the time and from weak hamstrings. And the other thing is never visiting hip extension, right? All the exercise we do is from here to neutral, and we never visit here unless we're in a full-on sprint, right? Or that butt blaster exercise that, if I ever see you on the inner and outer thigh machine, I'll make fun of you all day, but that butt blaster, the donkey kick, probably one of the best exercises you can do. And like with my athletes, when I'm rehabbing, especially hamstring pulls, I'm having them do, like, the best exercise to do is this right here. Just get up in the air and visit that extension, go into internal external rotation, and start to find out where you can cramp, just to be able to visit that 15 degrees, and the other side too, just because you don't visit it often on a regular basis. Any other questions? All right, so when we get into the hip now, we're going to change gears a little bit, because the hip gets more into like the musculature. And I'm not going to go through this joint motions as much. I might talk about internal external rotation. But what I like about this book is it starts to talk about the biarticulate muscles, the muscles that cross the two joints. And the two joint musculature is interesting because it plays with the dynamics of active and passive insufficiency. You're influencing the muscle participation by changing joint position somewhere through the kinetic chain. So you're either producing a shortening movement, a lengthening movement to either add or take the muscle away from it. So, like when you look at number 4, it's asking about the available range of motion. All that's doing is giving you an exercise to be able to visualize what hip flexion looks like, what hip extension looks like, shape some of the differences that are there. And you would see that in the hip, the largest amount of range of motion you have is hip flexion. The next is probably hip abduction, then extension and adduction, and then internal external rotation are your smallest amount of available ranges of motion. And if you were, I think I had brought this up in the last live session, that if you were going to assess someone, I would be assessing people in the transverse plane, like range of motion, to kind of see how things are moving, to get a feel for what's going on, because 1 or 2 degrees there is going to be significant. Whereas if I saw 1 or 2 degree limitation in, say, sagittal plane, not that big a deal, because in terms of percentage of range of motion, it doesn't mean a lot. But where we're going to jump in at, let me just look at 6 here real quick. Oh yeah, no, I do want to go through 6 real quick here. I got the femur. I should have. I thought I had a half. Oh. So if we look at the femur, it's really obvious that this is the convex surface, and the acetabulum, where it fits into, is the concave, right? It is literally the definition of a cave. It's a hollow cavern that this sits into, right? So never does this ever become the concave surface of and that becomes the convex. So when you're dealing with the arthrokinematics, you're dealing with the femur having to accommodate or at least get around the restriction of the acetabulum. And unlike the shoulder, this is a very there's a huge amount of contact surface there. So not only do you have like a huge amount of bone contact surface, you also have a labrum that goes around there that even enhances that even more. So this is a really congruent fit, right? And what's interesting is we try to identify like these axes of rotation, like the frontal axis and the sagittal axis and the transverse axis, but the hip joint's kind of like this at an angle. And so when you do flexion, you're kind of doing like this weird rotation. And we try to use these 90-degree, three-dimensional, nice planar movements, but it doesn't exist within the body. And I brought this up in the last live session about pronation, supination happening through the. I think I did. Now I'm getting confused if it was this class or I'm actually assigned. No, it's this class. The pronation, supination happening through the whole body because we were talking about the knee diving in from like the Q angle. But this is like a perfect example of where pronation, supination is happening. Is that when you do hip flexion, you're not really just doing hip flexion because the axis of rotation is not really here. It's kind of like this. So as I do hip flexion, I'm also doing a little bit of internal rotation and adduction that's coming through. It just happens to be the dominant movement where 90% of the movement happening is sagittal plane, right? When I do abduction, I'm doing abduction, but I'm doing a little bit of external rotation and hip extension to accommodate that, right? So that's that concept that triplanar motion is actually happening because there's nothing in the body that's three-dimensional and like nice perfect straight line or 90-degree angles. It's three-dimensional and it's like these weird arbitrary axis that's moving. So when we talk about this roll and slide and the arthrokinematics, just appreciate that there's a lot going on here in that. But as a rule, anytime that you're getting convex moving on concave, and this is happening for all three planes, as I roll, I have to, because if this is the rocker, this is the part that's sticking out, that's the part that's going to move. If I roll, I have to glide down in order to stay congruent in that position, right? So in situations where the pelvis is moving on the femur, so this is in closed chain activity when you're doing an anterior posterior pelvic tilt. Remember, like if you want to get confused of what hip flexion looks like, you always think hip flexion looks like this, where the femur is moving relative to the pelvis. This is how most hip flexion occurs, is like this, right? This is the pelvis going into an anterior pelvic tilt, coming forward and closing the gap there, right? So this motion and this motion are the exact same at the hip. It's just, is the femur moving relative to the pelvis, like in this situation, or is the pelvis moving relative to the femur in this situation? Now notice what I did there. If I did a hip hinge and I do appropriate hip hinge, I didn't constrain the shoulder girdle. So in this case, I'm spinal neutral. We just got done saying that an anterior pelvic tilt is associated with lumbar extension. Well, in this position, because I moved, it's not, right? I just did hip flexion, anterior pelvic tilt, and I'm still neutral. But the muscles that maintain this are those trunk extensors, right? So that's the equivalent of, hey, I picked my foot up off the ground. Even though I didn't do a pelvic drop, I maintained position. Which muscles were engaged to maintain that? So think of that too for like your anterior posterior pelvic tilt. If I do a hip hinge, if you're teaching someone how to bend over to pick something up, you're not, lumbar extension is not occurring, but if gravity took over, what would gravity do? I would drop down like that. So I'm producing my lumbar extensors to neutralize that. But just because the joint's not moving doesn't mean the muscles aren't involved. Okay, so any questions on the roll, the spin, the glide on this? Always going to be the opposite gliding with the rolling. So that's going to be for, especially for abduction and adduction. What's interesting about flexion and extension, and hopefully, let me see if they have the right answer here for that. Perfect, good. So with flexion and extension, oh wait a second, what is it asking? Oh, it's fine. Don't worry about it. It's good. It's good. Just appreciate that there's the rolling and the gliding. The one thing that I wanted to tell you is that as the rotation kind of comes in through here, that flexion and extension is kind of like a spin as well, like how you learn spinning from this aspect, because it kind of comes through from that position. Yeah, yeah, this is cool, fascinating. All right, so this is where I wanted to get to is number 7, looking at these biarticulate and monoarticulate muscles. Let's see if I can jump over the table here without knocking everything over. You're not going to be able to see me here, are you? All right, if I'm here, what joint? Okay, let's say I'm. Let's do this. So if I'm here and my foot, I'm at 90 degrees of hip flexion, 90 degrees of knee flexion, and my foot goes out, did I do hip internal rotation or hip external rotation here? If you see this visually, you see this and you see the foot go out, you're going to want to say external hip rotation, right? But if I straighten my leg out, my toes are pointed in. This is internal rotation, right? And it's deceiving because as the leg goes out, the foot goes in. And what's happening is if I'm here like this and I do internal rotation, can you see that that's pointing out? That's when you see the foot go out, just because the foot goes out doesn't mean that's external rotation, that's internal rotation. And if I'm here and I do this, so if I try to cross my leg, I'm going to try to take my foot and put it onto my knee here. That's external hip rotation, not internal hip rotation. That's because the hip is turning out as I'm doing that, and you can see that pointing down. So if I'm here and I do this, and I straighten my leg out, you can see my toes are going out. So probably feet, so it's good. So that's internal, external hip rotation. Everything else should be pretty straightforward, like hip flexion, hip extension, hip ab, and abduction. So what we're going to look at now are the combined movements. All right, so the first muscle that's on your list there for number 7 on page 217 is the sartorius muscle, and the sartorius muscle was that talar muscle, and that attached up at the ASIS, so right up here on this anterior superior iliac spine, and it comes all the way down and wraps around and attaches to that pes anserine, which is that triad of muscle attachments that's down here with the semitendinosus and the gracilis. And if I stretch this out and I hook it down there, what this would do, as I said, it's going to kind of create this bow-like motion here. And I don't know if you can see that well. Let me see if it looks better on this way from that. It kind of does this hip flexion, external rotation, and knee flexion. It creates that figure 4 movement that we kind of talked about, because it's kind of it comes to the medial side here. This hip flexion, external rotation, abduction, and knee flexion. It's creating that figure 4. And it's just got this perfect force line right here, right through there. Okay, so it's one of those weird, if you just think figure 4 and you can kind of reproduce that. So it crosses both the hip and the knee. And if I'm in this position and I straighten my knee out, so if I get into that figure 4 and then I try to kick out and stay in external rotation, I'd be lengthening that sartorius muscle, right? If I try to do, I need a stool, I need to jump up so you guys can see. Imagine me doing a figure 4 musculature here, and then from here, I try to bring I try to keep that figure 4, almost like You guys know what a hacky sack is? So it's like a little, like, you kind of do this motion here. So if I'm here, if I'm in a figure four and I keep my foot, like I'm in the sagittal plane, and I try to keep this position and I try to come up, like I can feel my sartorius cramping right now, because what's happening is I'm already kind of shortened here. I've flexed at the knee and I've abducted, but it still crosses the hip. So if I try to maintain this position and I try to come up here, I'm shortening even more. And so I'm putting the sartorius further into a shortened position, and it's starting to cramp. If we were in class right now, I'd have all you guys do that, where you do this and try to really maximize external rotation, and you'll feel it. You're like, it's not happy, right? Let's skip the extensors real quick and go to the last three at the bottom, and then I'll flip the skeleton over. So we'll look at, so for the sartorius, you would have the lengthened position would be the opposite here, would be if the shortened, do the shortened position first. On the right side, it's flexion, abduction, and external rotation. And it does flexion at the knee. So that's its shortened. So I'd be kind of getting into this position here. And then your lengthened position would be the opposite. It would be extension, adduction, and internal rotation. So it would be like you, if I was here and me trying to get my right leg back behind me and touching way over there, like behind my left heel. And that's how you would lengthen or try to stretch that muscle. All right, let's go to rec fem. So the rectus femoris is one of those quadricep muscles, and it attaches down, originates at the AIIS, and then on the acetabular ridge. It comes in right through here, right through that. That's your AIIS in here. And it comes down, and then it converges into the quadriceps tendon. So it attaches at the suprapatellar tendon, and then it ends up down here at the tibial tuberosity, right? So unlike the other three quadricep muscles, it does hip flexion, but it also does knee extension like the other three. So it's the knee extensor and a hip flexor. And so if I wanted to maximally shorten this muscle, I would try to keep the knee as straight as possible and produce hip flexion as much as possible. So leg straight. And we already know that this is kind of a hard position. What do most people want to do when they're trying to stretch their hamstrings? They want to cheat a little bit and they want to stretch. And what's happening is, as I go into this position with my leg straight, I'm maximally shortening my rectus femoris. At the same time, I'm maximally lengthening my hamstring. So both the semitendinosus and semimembranosus in the biceps femoris long head. So remember, it's like a tug of war. You can't have one without the other. So in this case, as I'm maximally shortening my rectus femoris, I'm maximally lengthening my hamstring muscle, the short head of the biceps femoris. And then so if I wanted to maximally lengthen this guy, I would do the opposite. I would do full hip extension with knee flexion, but I'll show that as we flip that over. So if I wanted to stay in mid-range for the rec fem, I would be right here. I would be, as I'm getting shorter in the hip, I'd be getting, let me pull on the other side here. As I'm getting shorter at the hip, I would want to try to lengthen it there, and I would bend the knee. So bringing your knee up to your chest like that. Basically what's happening is that rectus femoris muscle length isn't changing at all through this entire range of motion, right? Because as it's shortening here, as it's pulling this together, it's lengthening, it's giving it the same amount of resistance or slack at the knee. So when you bring your knee to your chest, that's like your rec fem staying like a cable the entire time, right? Same thing with your hamstrings. They're doing the same thing. They're kind of staying like a cable. And this is the foundation for hip stabilization during squatting, right? During the sit to stand. The last hip flexor here is the tensor fascia lata, and that's the muscle that originates up here at the ASIS. And that comes down and it has 100% of its attachment into the IT band on the side of the leg, so there's no bony attachment. But if this guy shortens, because it comes out a little bit, because of the bulk of the leg muscle, let's say this is muscle tissue, it would be there, so it would come all the way out to the side like that. So it kind of comes here and kind of comes down a little bit. And so if it comes in from here towards the side of the leg there, actually from here down towards the back of the leg, you can see that it has to pull the leg out a little bit. So it does 3 motions. It does abduction, it does hip flexion, and I said that these fibers have a little bit of internal rotation to them. So leg kind of at rotation for the TFL. Surprised they have the TFL on there as a biarticulate muscle. So the reason why they have the TFL on there is because the IT band comes all the way down and actually it crosses the knee at Gertie's tubercle right here below the at the tibia plateau. So it could be involved in knee extension. So it does that hip abduction, hip flexion, and in order to maximally shorten it, you'd have knee extension. So hip flexion, hip abduction, hip internal rotation, and knee extension for full shortening of the tensor fascia lata, and then you'd have the opposite movements for lengthening the position. Any questions on the flexors? All right, so if we go to the back and we go up to the hamstring group, the way we work with this now is that the hamstrings all basically work the same, except for their participation in tibia internal external rotation. That's more of a knee aspect. But in terms of the hip and primarily at the knee, they all do the same thing except for the short head of the biceps. And remember, the reason why is that these muscles are attaching here at the ischial tuberosity. So they're right here at the ischial tuberosity, and they're shooting down, and the semitendinosus is going laterally in front of the knee into the pes anserine, and the semimembranosus is kind of blanketing down, hitting the, I'm sorry, did I say laterally? I meant medially, hitting the posterior of the tibia. And then you have your biceps femoris, both long head and short head. They're coming down and attaching to the posterior aspect of the fibular head on the lateral side. But the long head of the bicep originates up here on the ischial tuberosity. The short head of the bicep is originating on the bulk of the linea aspera. So they are involved in hip extension, so bringing back, and knee flexion. So if you wanted to maximally shorten these guys, you would extend the hip and flex the knee. And then I showed you with the rectus femoris, this is also how you would stretch the rectus femoris. You would put someone prone, kind of grab under their knee. You actually will do it. You're like this, and but the leg wouldn't drop like that. And you are pulling up, and then you're kind of pushing into further into knee flexion to fully lengthen that rectus femoris. So as you put yourself into as shortest position as possible, passively insufficient hamstring position, you're putting into an actively insufficient hamstring position, you're putting yourself into a passively insufficient rectus femoris position. So you're getting both of those movements. So one of those strategies, if you look, remember we talked about hip extension being one of those weaker issues, and where that comes up is lack of glute involvement and too much hamstring dominance. And when you do a supine straight leg raise, you can influence a little bit the musculature. If I keep my leg straight and do hip extension, I'm getting glute max involvement and some of those other glute medius fibers, but my hamstrings are also involved as a hip extensor. If I flex my knee and then do this, I'm putting my hamstrings into a or physiologically disadvantaged position. I'm putting them into an actively insufficient position. So if I try to bend my knee as much as possible and then do hip extension, my hamstring gets taken out of the game, and what's left is just the glute max. And so if you were working with a patient that is, or an athlete, like a training aspect that has chronic hamstring pulls, usually when you see a pulled muscle, it's because the muscle was doing too much work or overuse, usually doing too much work. And that's could be, not always, but could be indicative of glute max, poor glute activation. And so one of the things I would do is I would try to get the glute involved, and you can do different things with the glute. The glute max does hip extension, It does external hip rotation. So if you have someone on the table and they want to do external hip rotation, remember the foot's not going to go out. That's going to be internal hip rotation. But if the glute max was to do its job and do everything in a shortened position, it would abduct a little bit. It would externally rotate, and you would go up into a hip extension. And actually, a really good exercise to kind of work with the glute is to hang off the table and almost do like a figure four where you're like this, but now your knees kind of down off the edge of the table, and all you're trying to do is bring your knee out like flaring up that way. And you're using the glute max fibers not just as a hip extensor, but as a abductor and external rotator. Oh, so that I just answered number 8 with the hip flexion and extension. With a hip extension with knee flexed or extended. So 8 then, 8 just over with glute max. If I wanted to, if you look at the hip extension with knee flexion in prone and hip extension with knee and extension, the musculature is the same. This is glute max and hamstrings, right? Glute max and hamstrings doing this, and glute max and hamstrings doing this. In this position, hamstrings are able to stay in mid-range for a bigger part of it, so they're going to be able to participate. Glute max participation is the same regardless, right? So whether I have my knee bent or knee flexed, extended, it's not going to influence glute max much. Some would argue that part of the attachment is in the IT band and it kind of goes through there, but that's a negligible aspect. Who has a bigger effect is the hamstrings. Here, I'm putting my hamstrings in a disadvantaged position. Here, I'm allowing hamstrings to stay more in mid-range. So the hamstrings are able to take on more of the responsibility. Think of you and a buddy trying to push a really full shopping cart. When the leg's like this, you guys are both pushing at the same time. When the knee's bent like this, the one is starting to just push with one hand instead of two hands, which means that you have to do more work if you're the glute max. Okay. Number 9 gets us back to this guy here. So if I'm standing here and I'm doing, it says you turn to the, let's see. Okay, so if I'm standing here and I don't pick my feet up off the ground and I turn to the left, what motions are occurring here at the hip? So we looked at pelvic motion in the sagittal plane and in the frontal plane. So we said that if we do a left lateral or left pelvic drop, we're doing hip abduction on the left and hip adduction on the right. So we look at pelvis rotation. If I rotate my pelvis to the left, this part of the pelvis is coming backwards, the right side's going forward, and vice versa. If I go to the right side's coming backwards, left side's going forward. So if my feet are stable on the ground and I'm stable and I turn my pelvis to the right, or even if I just turn my whole body to the right, and I turn my whole body to the left, where the shoulders go, the hips are going to want to go. My feet are on the ground. What joint action in the sagittal and the transverse plane am I creating at the pelvis? So if I'm here and I'm turning my pelvis to the left, did this distance here between the femur and the front of did that get closer or further apart?
Closer.
It got closer. So that's the equivalent. Now, if I look here and if I look at external rotation, internal, if I look at external rotation, or this is where calling external rotation lateral rotation and internal rotation medial rotation might be clearer. Remember, external rotation and lateral rotation are the same thing. Internal rotation and medial rotation are the same thing. So in this case, this is this is getting closer medially. So this is creating internal rotation. So if I turn to my left, I'm getting medial rotation or internal rotation of the left same side, and I'm getting external rotation because this got bigger, right? This moved more laterally away from midline. This is now lateral rotation or external rotation. So it's just the way the pelvis is moving as I'm turning to the left. It's creating internal rotation to the same side. And if you have trouble seeing that, sometimes looking at it from here, this view, let me see if I can do it this way. So here my feet are neutral. This is where my feet would be standing up. If I turn my pelvis to the left, can you see that it this is internal rotation and this is external rotation? Can you see that if I'm holding here and I just do that this is jamming closer together and this is getting gapping further apart? And if I turn to the right, I'm getting ipsilateral or same side internal rotation and opposite side external rotation. Now this is only true if both feet are on the ground. If only one foot's on the ground, I don't know what's happening on this. So if I just my left leg's on the ground and I pick up my right leg and I turn to my left, I'm getting left internal rotation and who knows what's happening at the right hip. I don't know. And if I turn to my right, I'm getting external rotation of that left hip. The second part of number 9 is a review from the previous. It's looking at the hip hike. So if I do a left hip hike, that's the same as a right pelvic lateral tilt. And my right leg stays on the ground. What happened at the right hip here? Did this do hip abduction or adduction? If this left side got higher, so I'm standing here, and here's my right leg, and I lift my hip up, can you see that my whole pelvis moved that way? That's the same as me kicking my leg out to the side. So this is hip abduction. That's just that motion there, right? So that's that left hip hike. So left hip hike, as this is coming up, or the right pelvic hip drop, and my right leg's on the ground, that's going to be doing hip abduction. Let's do this now. I'm adding another part to the question. Let's say my left leg's on the ground, and I do a left hip hike, but I can't do a left hip hike. I'm gonna keep my left leg on the ground. I'm gonna do a right lateral pelvic tilt, which is the same as a left hip hike. What joint action happened at the left hip? That's the same as my leg coming in, right? You guys can kind of see, it's hard to see between the skeleton, but if this is dropping in like that, that's hip adduction, adduction. Okay, let's do 10 because 10 is like a really good thing to do. Just positional analysis of these movements here. So first, let's say this guy was standing and he went to sit down. Was that an eccentric activity or concentric activity that he did to do that? The answer is eccentric, right? He's going with gravity, okay? He's controlling with gravity. What joint action did he do in order to do that when he went from a standing position to a seated position? Hopefully his spine stayed neutral, and it looks like it did. He looks pretty erect there, and it's safer to say that if you're going to have any distortion in the spine, it's going to be more prevalent in seated than in standing. What joint action at the hip did he do? In this position, you can see that looks like hip flexion and knee flexion. In order to go into hip flexion, what is the pelvis also doing? The muscles that do the joint position of hip flexion also does what to the pelvis? Hip flexion should be tied with an anterior pelvic tilt. That's it. That's biomechanically ideal. Most people, when they're sitting, they a lot of times are doing a posterior pelvic tilt, right? When you sit, you should be in an anterior pelvic tilt, but since we are weak and we sit so often, we kind of slouch and we go into this posterior pelvic tilt. So like that's, if you want to look at the appropriate biomechanics of sitting, that's why if you look at any quick article, you do a quick search online for back pain, they say sitting is the worst thing. Well, sitting is bad if you are doing this all day, right? it's okay if you're in this position. All right, so that's the starting position. In order for him to go from a seated position to a standing position, so we're looking at number 10. What and he went forward, but no lumbar flexion occurred, right? He didn't flex through he looks pretty straight. If you were to draw a line from the back of his head here, you would see, so if I have a dowel rod, if I'm spinal neutral, I have my tailbone touching the thing, I have the back of my head, and I can keep my spine neutral and not be erect, right? I'm erect here, but now I'm 5 degrees, 10 degrees, 20 degrees. Now I'm getting down. I'm keeping spinal neutral the entire time. So me bending forward is not me bending at my spine forward, right? You can see the difference here bending forward versus here bending forward. What in figure 1827, what's happening there in order for him to lean forward? He's keeping his spine neutral. He's doing an anterior pelvic tilt, and it's produced by the muscles that do hip flexion. But it's not the hip flexors that are doing that. Is that a concentric activity or eccentric activity? Gravity wants to pull him which direction? Down. So he's not going further into that. That's actually the hip extensors that are working to control that eccentrically. Because if you go to stand up now, if you're in that position and you go to stand up, which muscles are firing when you go from 1827 to 1828? I don't think you would tell me that hip flexors are working there. I think you would tell me like the hamstrings, the glutes, the gluteus, the hip extensors are working there. This is where, and this will be on the exam, and students get this wrong all the time, is that if you analyze a movement like the squat, or in this case, sitting down into a chair, you would say, I would ask you, what joint motions are you seeing? And you'd say, oh, I'm seeing hip flexion and knee flexion occurring. And then the next question might be, which muscles are involved? And you're going to, because you see hip flexion and knee flexion, you're going to say knee flexors, hip flexors, but that's wrong. Because this is not the concentric phase, this is the eccentric phase going with gravity. I'm going to sit down. And if you were to stand up and you put your hands on your glute and you go to sit down, yes, I'm doing hip flexion, but that's the eccentric phase. That's the glute max working eccentrically. And in this case, I'm reversing the motion back down, what we actually did when we started. And so you're maintaining this anterior posterior pelvic tilt, but this is actually being managed more by the lumbar extensors, by the whole extension chain, the posterior chain, than it is the anterior chain. And so you're doing this, you're keeping the pelvic neutral as your latissimus dorsi, your erector spinae, and of course your glutes are working as a hip extensor as you're coming down into that seating position, and then it's the same muscles that are driving you up from a seated to a standing position concentrically. Perfect. Any questions? So we went a little long. I went on a couple tangents with the glute and the hip extension type stuff for like exercises for that, but I think that's like pertinent clinical stuff. The big takeaway from this chapter in the last, the biarticulate muscles, how you would maximally shorten or maximally lengthen muscles that cross both the hip and the knee. Really understanding, you can see it came up again in this chapter, the coupled movements with the pelvis position and what's happening at the hip. So when you do left pelvic rotation, what's happening there, and knowing like with the, if you can work through this, and I'll post the answers for this for the I don't even know what number this is. I think it's number 10. Yeah, number 10. and being able to analyze the muscle activity during going from a seated position to a standing and back down to seated, really understanding the difference between concentric and eccentric and knowing who's working. I think you got everything you need from this unit, minus knowing the exact muscles, the attachments, and the neural innervations. But in terms of a functional application thing, I think that's what's going to be it for the hip and the pelvis. And then next week we'll do the knee and look at some of those musculature, and then we'll do the knee and ankle on Friday next week. Any questions? Helpful? Was this good?
Yeah, this was a nice presentation to have everything worked out like that.
And I think the timing was good, where we were able to kind of go through